Good afternoon, dear colleagues. Welcome to our webinar on facing ethical dilemmas as a psychiatrist. My name is Meryam Schouler-Ocak. I'm Professor of Intercultural Psychiatry at Charité Universitätsmedizin Berlin, and I'm the chair of the Committee on Ethical Issues. I'm very happy now to introduce our distinguished expert, but before, let me say a few words to this webinar. This is one of the planned webinars of our Committee on Ethical Issues. You know that the EPA has developed Code of Ethics, which was approved by the General Assembly 2021. In this Code of Ethics, we have fixed fundamental values, and some of these values are, for example, that we psychiatrists must uphold the responsibilities and ethical demands of the medical profession and specific to psychiatry and working with mental health. Psychiatrists, so we should consider the ethical principles of respect for the autonomy, beneficence, non-maleficence, and justice. Furthermore, we psychiatrists hold the obligation to advocate for universal healthcare for everyone and appreciate prevention, care, treatment, and rehabilitation for persons with mental disorders within available resources in their respective countries. So we are very, very happy that we could win two very distinguished experts in this field. And now the first speaker of our webinar is Dr. Jan Weiss. Just before giving the floor to Dr. Jan Weiss, I would like to mention that you can, if you like, of course, enter your questions or comments using the chat. We will have the discussion part after both talks. So I'm happy if you enter question, comments, and so on. So our first speaker is Dr. Jan Weiss. Dr. Jan Weiss is NHS Consultant in General Adult Psychiatry, working in a busy inner city area, responsible for the provision of long-term care for over patients with severe and enduring mental illnesses. He has been instructed in class actions involving defective products and civil rights violations. During the COVID-19 pandemic, he was a member of the CNWL NHS Trust Free Wise Men Ethics Panel. He provides support and training to a suicide reduction charity, the Samaritans. He is a fellow of the Royal College of Psychiatrists and a distinguished international fellow of the American Psychiatric Association, as well as an honorary member of the World Psychiatric Association. Dr. Weiss was elected to the board of the European Psychiatric Association in 2019 and awarded the Association Medal of the British Medical Association for sustained and meritorious service. As chair of the British Medical Association's Medical Legal Committee, he regularly liaises with the Ministry of Health and Justice and Medical Defence Organizations. He was elected chair of the British Medical Association's Medical Ethics Committee and sat on boards of the European Psychiatric Association and the World Psychiatric Association. I'm happy now to listen to Jan Weiss. His talk is on termination of pregnancy, good intentions paved the way, and an analysis of a high-profile recent care in the UK. Jan, the floor is yours.
Thank you very much, Meryam, for that very kind introduction. I didn't realize quite how long it went on for, but it's lovely to see everybody here after lunch. I hope you're all adequately caffeinated to avoid that postprandial slump, and that we're going to keep your attention. Lara, if you could go to the next slide, please. Now, whilst this is set in the UK, many of you will already know that the United Kingdom isn't a single jurisdiction. It's 4 countries with 3 different major legal systems, England and Wales, Scotland and Ireland. But there are 4 other systems that fit within that: the Isle of Man, the Channel Islands of Guernsey, Herm and Jethou, and the Channel Island of Jersey. And you can see from these dates that I've put in this slide that they've each brought in legislation and changes at different periods of time. Next slide, please. Now, it's the case that in England and Wales, Scotland and Northern Ireland, except in the described circumstances, the termination of pregnancy is illegal. It is still a criminal act unless 2 registered medical practitioners in an NH hospital or premises approved for this purpose certify one of the following 4. A is that the pregnancy has not exceeded its 24th week and that the continuance of the pregnancy would involve risk greater than if the pregnancy were terminated of injury to the physical or mental health of the pregnant woman or any existing children of her family. Or B, that the termination is necessary to prevent grave permanent injury to the physical or mental health of the pregnant woman. So note with B, there is no upper limit. C, that the continuance of the pregnancy would involve risk to the life of the pregnant woman greater than if the pregnancy were terminated. And your obstetric and gynecological colleagues will point out to you that a termination of pregnancy is a less risky procedure than delivery. So that tells you something there. Or D, that there is a substantial risk that if the child were born, it would suffer from such physical or mental abnormalities as to be seriously handicapped. And the legislation doesn't describe what seriously is. Next slide, please. Now, lest you think that this has generated a free-for-all, 90% of terminations of pregnancy are carried out at 13 weeks or earlier. And that frequency or percentage has remained relatively constant over the past decade. And the overwhelming reason, 98% of cases, is that the continuance of the pregnancy would involve risk greater than if the pregnancy were terminated of injury to the physical or mental health of the pregnant woman. Next slide, please. So to put this in its European perspective, and this is really fresh data, this is from Friday, it tells you how different countries regard the limits of termination of pregnancy. You'll see the countries in purple have it available effectively on request in the 2nd trimester. The countries in orange, there are certain conditions which allow it in the 2nd trimester. And in Andorra and the Vatican City, a 2nd trimester abortion is completely illegal under any circumstances. Next slide, please. Now, times change, technology changes, circumstances change. And when COVID came along, you'll probably appreciate that we didn't want everybody in hospital. And you'll also have realized that medical abortions, taking tablets, enable a safe ending to a pregnancy. And does that have to be in hospital? And the UK England and Wales introduced some changes enabling that. They also passed legislation allowing the assessments to be remote by telephone or video consultation, and prescribing of the medical abortificants was facilitated. Next slide, please. Now that's important because it lays the background for a case that was prosecuted in the summer of 2023. A mother of 3 receives medication under the pills by post scheme. It's supposed to be for unwanted pregnancies up to 10 weeks with a remote consultation. Now, the prosecution said that the woman knowingly misled the British Pregnancy Advisory Service, a charity which provides the majority of termination of pregnancy services in the UK, effectively a contractor to the National Health Service. And she misled BPAS by saying she was less than 10 weeks pregnant, when she believed she was about 28 weeks pregnant. Now, pathology looked at the fetus, and they determined that the fetus was about 32 to 34 weeks of gestation at the time of the termination. The court also heard that her computer revealed internet searches with titles such as, "I need to have an abortion, but I'm past 24 weeks," and "Could I go to jail for aborting my baby at 30 weeks?" So it was put to the court that the woman ended her pregnancy beyond the lawful time limit during lockdown, and that she knew full well that her pregnancy was beyond the legal limit, and that she deliberately lied to procure the drugs to do so. Next slide, please. Now, perhaps unsurprisingly, whilst this was being prosecuted, things like this went out on social media. "Women deserve compassion, not prosecution." Hashtag time to act. And the Royal College of Obstetricians and Gynecologists and the Royal College of Nursing and Midwifery wrote to the judge stating a custodial sentence would deter women from seeking necessary care. But what you need to remember is this isn't about the inadequacies of sex and relationship education in England and Wales. It's not about the problems that make it difficult for women to access effective contraception. It's not about the barriers that certain members of society face in accessing healthcare or health information in a timely fashion. The crux of the matter is, did this woman lie to get something that was not lawful for her? Next slide, please. So, the Royal College of Obstetricians and Gynecologists and a group of others, and as chair of the BMA's Medical Ethics Committee, I sat in that group and I listened to the arguments, but we didn't put our name to the letter. They wrote to the judge to say, "We plead to your honour to consider leniency in this case. We are fearful that if the case before you receives a custodial sentence, it may signal to other women who access telemedical abortion services or who experience later gestation deliveries that they risk imprisonment if they seek medical care." Now, the way it was worded, it read like this was a reason not to find her guilty. And guilt or innocence is about the facts of the case and are the legal criteria met. The sentence is a different matter. It serves several purposes: punishment, rehabilitation, and deterrence. And in my mind, had the letter focused on the deterring effects, it might not have come in for the criticism it did. The judge said the letter was inappropriate, adding that he does not accept that imprisonment in this case is likely to deter women and girls from lawfully seeking abortion care within the 24-week limit. Next slide, please. So the judges made it clear that imprisonment would not deter women from seeking lawful care, which is what the letter authors were concerned about. And she received incarceration of 28 months. Now, it happened that during the trial, she decided to plead guilty. And the judge pointed out that if it had gone all the way to the end, the sentence would have been 8 months longer. To put it in context, the potential maximum for this offence is life imprisonment. It's never been given, but it's potentially there. And the bit to focus on is the absolute tragedy of this case was that if she had pled guilty at the earliest opportunity, because he accepted she was remorseful, he accepted there were children at home. But if she had pled guilty at the earliest opportunity, she would have served no time in prison. She would have got what's known as a suspended sentence. So that's the real tragedy here. It's not that a woman was driven to this. It's that she didn't get the right advice that you have done wrong, own up to it, and you'll be okay. Next slide, please. But every stone that begins rolling down a mountain gathers momentum and causes change. And this was the headline that followed the trial on the 12th of June 2023 in one of our more socially responsible newspapers. Outrage at jail sentence for woman who took abortion pills later than UK limit. It's actually had some really positive effects. The outrage meant that the British Medical Association and regulator of doctors, the General Medical Council, had some very detailed discussions. And from where it was before, that if you suspected a criminal offence and there were certain members of healthcare who don't agree with termination of pregnancy, they were taking these opportunities to report these women. It shifted that balance that you're not under an obligation to report this. And if you do think about reporting it, you have to document carefully why it is in the public interest, and that interest is greater than both the patient's and the public's interest in keeping the information confidential. So very publicly, it has changed the balance against reporting this. It also enabled people who are interested to get some legislation over the line that we've been trying to get passed for over 5 years. Safe access zones. That's legislation allowing clinics that provide these services to ban any type of demonstration, whether it's a prayer vigil or people approaching the clinic, whether it's 100 meters, whether it's 150, they can't come within that distance during hours of operation. And it makes it a more or a less unpleasant experience for those who need this service. And it has led to the presentation of potential legislation to the parliaments in Scotland and England and Wales to change the legislation. If you remember at the beginning, I said this is criminal unless the following has happened. These bills will stop it being a criminal offence. It will still be regulated, and doctors may still be disciplined for providing it wrongly or inappropriately, but it won't be criminal. And the women who need the services will not have to jump through the hoops that they do at the moment. Next slide, please. So what I wanted people to take home from this, it's an example how there is a common problem and each country has its own laws. What may apply in one country may not apply in another. And none of us are doing it absolutely right. We all have mechanisms for altering legislation to reflect the wishes of the electorate. And each of your laws will reflect the history of your countries, the social development, and people's thinking. And that's how you're here today. And it's merely the start. And you and your actions will make tomorrow. And if you wish to see social change, there are ways of doing that. So in summary, any problem has a path you have to follow by legislation. And to a large extent, considerable amounts of ethical behavior are about what is lawfully appropriate. And once that has been determined, you then have room for maneuver. So that's the end of the primary topic. Meryam, do you want me to address some of the questions that were asked, or what would you like to happen next?
I think we can get back to the questions after this next talk and discuss together. Maybe there are some understanding problems or questions regarding understandings, not the questions which are addressed, which were pre-registered. Are some understanding problems which should be clarified? If you have some understanding problems, you can enter it to the chat. If not, we will go on with our next speaker. Thank you so much, Jan, for this very touching topic and really ethically controversially discussable topic. We will get back to it after the next talk. Thank you very much. It was very impressive. So I'm very happy now to introduce our next speaker. He's also a very distinguished colleague. It is Professor Rutger Gaag. Professor Gaag is Emeritus Professor of Psychiatry, Redboundung in Netherlands, and Psychosomatics and Psychotherapy in Stradina University, Riga, Latvia, and at the University Paris Cité, France. He is past president of both the Netherlands Psychiatric Association and Royal Dutch Medical Association. As member of the Council of the World Medical Association, he was involved in the renewal of the Physicians Pledge. He served EPA as founder and secretary of the Council of NPAs, board member, and full terms on both the Committee for Education and Ethics. He is currently member of the board of directors of the European Institute for Women's Health and chair the Dutch Association of Healthcare Executives. It's very interesting what you also have done till now, Rutger. So we are happy now to listen to your talk on mental pain and suffering poses an ethical dilemma to each psychiatrist. So the floor is yours.
Thank you. Thank you so much for your kind introduction, Meryam. I think that one of the things that was missing in the introduction was that I started off as a general practitioner, and in that sense have been very actively involved in the questions we're going to face. Please, can I have my presentation? So next slide, that is the introduction. What we're going to talk about today is the ethical dilemmas that we face when people with psychiatric problems or diagnoses ask for an application of the legislation of medical assisted dying, or as it is put in the United States and Canada, physician assisted dying. We will start with looking into the February issue of the World Psychiatric Association Journal, where two articles really articulate the debate that is going on. Then I will stop by looking at some sad connotations, because the word I was not using and that I will not use, but that has come into fashion, euthanasia, has a very bad connotation. Then we'll look into what kind of situations we have worldwide with regard to legislation to physicians-assisted dying, and we'll discuss the moral dilemmas. Next slide. Here you see this is a copy of the front page of the of World Psychiatry, the official journal of the World Psychiatric Association. It dropped down last week, and it's the February number, and there are two contrasting articles. The first one by two Belgians, De Hert and Van Asse, and they say euthanasia for unbearable suffering caused by a psychiatric disorder, improving the regulatory framework. And that is something that's very important. As you know, in the Netherlands and in Belgium, the legislation for physician-assisted dying was established 21 years ago in 2002. Interestingly, in both countries, it were the physicians that were the ones that asked for this legislation because, as I told, as a general practitioner, we were very often confronted with the fact that patients with terminal illnesses, neurological, cancer, were begging for pity when suffering unbearably without us being able to give them any support or any hope for recovery. And in those days, pain killing was still rudimentary, and the only the only thing we could do was wait till their agony ended. When the law came in, it was a law with checks and balances that made sure that it was the will of the patient and not of the family or anyone else that was determining the wish to have physician-assisted dying and to die with dignity. This is very important because when I joined the World Medical Association in 2013, at my first introduction, I gave a talk about the Dutch and Belgian legislation. And at the end of the talk, the representative of the Vatican said, "You are a murderer." Well, he wasn't addressing it to me personally, because in my life, I've never personally been able to help someone terminate his life. But what he was meaning, that was that the law on help with by suicide by the Dutch and Belgian legislation led to a murder. My reply was, "And what do you do?" And then he said, "We give morphine and more morphine and more morphine, and then the patient dies a natural death." My big problem with that statement is that palliative sedation is a doctor conducted act. And the problem is that you do not know if the doctor has been listening to the family, has been listening to his own options, or if the doctor is generally according to the patient's need. In March next, in Canada, where the physician-assisted dying was not asked by the physicians, but by the general public, where the legislation was put in place by town hall meetings all over the country. In March, the Canadian legislation will, for the first time, allow patients not only with physical pain, unbearable pain, but also with mentally unbearable pain, to ask for a physician-assisted dying if the checks and balances are in order. And in most of the countries where this is done, in normal cases of cancer or of neurological diseases, one doctor, apart from the treating doctor, comes to check if all the precautions have been taken, and if it's really the will of the patient, so someone with dementia will not qualify because they are not capable of expressing their will, and any person not capable of expressing his will not qualify. But then in the case of psychiatric patients, two independent psychiatrists will have to look into it. Before moving into the ethical dilemmas, let us look at the sad connotations. Next slide. Our very respected colleague, Professor Schneider from Germany, wrote this book, Registered, Persecuted, and Annihilated. And the picture you see on the right-hand side is the Philharmonie in Berlin. And the wall you see is a wall of shame about what happened during the Nazi regime, where the Nazis were killing people with any form of disability, mental disability, psychiatric disability, or physical disability. And they did that for two reasons. One was they said these people are far too costly. Taking care of them is being subtracted from the budget that we have to help other people. And the second one was genetically, they are a shame for our population. Well, I have difficulties in pronouncing these words, but that is what the euthanasia program of the Nazis was about. And what we see nowadays in the discussions about the physician-assisted dying is that every time from the people that are strongly opposed, and we go back to the previous slide, like, previous slide, please, like Paul Applebaum from the United States, say a doctor should respect life and will not terminate life. And other people that are fiercely opposed to any form of physician-assisted dying, and the World Medical Association to date still is, say, if you indulge in physician-assisted dying, you will indulge too in killing people for economical reasons. And I really do not think that is the case. Let's look 2 slides further to see what the worldwide situation is. Here you see in blue countries where physician-assisted dying is permitted eventually in cases of psychiatric patients, in blue on the in dark blue on the European map. It's interesting to see that Germany is included on the left-hand map and not on the right-hand map. In Germany, it is not, it's legally allowed to provide a means for people to commit suicide themselves. So it's not the physician that administrates the drugs, but it's the person itself. We see in green countries where the only way to qualify for physician-assisted dying is having a doctor stating that you only have 6 months to live, which is never the case in psychiatric patients because you cannot estimate that. And you see that Portugal and Spain now have legislation. There's a big debate going on in a commission in the House of Commons where I testified, and there is a big debate going on in France too. So let's go to the next slide and see what are the moral dilemmas when we look into psychiatric physician-assisted dying. The first thing is the contradiction in the medical oath, where in one article it says the uttermost respect for human life, and the other one, thou shalt not harm. I've been talking about the legal safeguards that in the legislation in the country where physician-assisted dying is allowed, we see that there are checks and balances, and that it's not the physician that can administer palliative sedation without any checks and balances. One of the very important things about the Dutch and Belgium and Luxembourg law, but also in Canada and in other countries, is that when it comes to suffering, there's no difference being made between mental suffering and physical suffering. And we all know that there are many cases, there are 2 or 3 studies where people that had had both a depression and cancer and had survived both were asked, what would you choose if you were to have one again? And all those patients chose for cancer, which means that having a depression in terms of suffering is maybe worse even than the physical pain that terminal patients have in neurological or cancer situations. I must say that in my clinical practice, in the 40 years I've been a psychiatrist now, I've only had 1 case of suicide. One of my patients committed suicide, but I've been involved in the aftermath of many, many, many cases of suicide. And we see that in suicide, the mourning for the family is extremely difficult. Suicide, which is the lethal end of many psychiatric conditions, and that we try very hard to avoid, has a huge aggressive impact on the family. And now, over the past 4 or 5 years, I have been working with families that had a relative, a child, a brother, a sister, a son, a daughter, with a psychiatric condition that seemed intreatable. Here, I must say that in 2016, in the Netherlands, there was a clinic called the End of Life Clinic that opted for physician-assisted dying in cases where the GP or the treating physician would be reluctant to offer that. In the first year, there were 700 cases that were presented, and about 670 of those were psychiatric patients. After having spoken to all these patients, after having assessed them by having them had assessed by 2 psychiatrists independently, only 14 qualified for physician-assisted dying, and that were cases where everything had been tried, where people had been in psychiatric care for many, many years, and where nothing seemed to work, and they got a physician-assisted dying. And then the concern was that maybe all those other people that did not qualify would kill themselves. None of them did. We had interviews with these people, and they said, I've been taken seriously. I've been talking to 2 independent psychiatrists. My own psychiatrist was always saying, oh, you're suicidal, and that is part of your depression, that's part of your psychosis, that's part of your psychiatric personality disorder. But they had the feeling they'd been listened to, and some of them, most of them, had been given some advices. So I think that when you look at the Belgium and the Dutch situation, about 1 in 100 of the physician-assisted death is for a psychiatric patient. And I've been working with the families of those that receive that physician-assisted dying. And I realize that the process of mourning is much easier when the parents, the brothers, the sisters, the relatives have been able to bid a farewell, have been witness of tremendous suffering over a couple of years, and then they have much more peace when the patient has died through physician-assisted dying than when the patient has isolated himself or herself and committed suicide. I must confess that I have never, ever in my life been able to perform physician-assisted dying. And in all the countries where it is legal, no medical doctor is compelled to do so. What I've been doing is I've been offering patients the means to commit suicide. And in the 40 years of practice, I've been doing that very often in cancer patients, in my own patients with psychiatric disorders. No one has ever used them because the apprehension to become dependent on a doctor that would comply to help them was bigger than their need for assisted dying. And they all died in peace. And that's where I want to finish and open this for discussion.
Thank you very much, Rutger, for your really also very impressive and touching talk. Your last words were highlighting in me some feelings. So you mentioned that no of these patients you have talked to committed suicide, and they all were peaceful.
Yeah.
And they were all satisfied, or what happened there?
Well, I started when I was a GP, so that was in the 70s, and there was no legislation in the Netherlands. And I was training, and they said, you know, the fear for unbearable suffering is huge in psychiatric, in all patients, cancer patients. And in the GP practices where I worked, we would give them a box of barbiturates, with which they could kill themselves, and no one ever used them. But what we did, we paid them a visit every day till they died. And in psychiatric patients, most of the time they gave it back and they said, well, I don't need it. When I became a consultant in the oncology department of the hospital, the same thing happened. I was working in the cancer unit of the Children's Hospital. And in those days, that was in the 80s of the last century, there was no cure. These children had terrible suffering, they had pains, sarcomas, things like that. And one of the pediatricians I was working with always said, you know, they're afraid of two things. They're afraid of suffocating, and they're afraid that they will have more pain to endure than they can stand. And we just gave that box. We weren't allowed to publish it, obviously, because it was completely illegal. But the parents were informed, the youth was informed, the direction of the hospital was informed. And I would come every day. I postponed holidays and things like that. So I was always there. And they all died, unfortunately. And I could just retrieve the box. It was never used. So in my view, what is happening now, and I'm very concerned about that in the Netherlands. When you look at the total number of people that die in the Netherlands, 170,000 a year, about 4,000 die with physician-assisted dying, of whom 100 are psychiatric patients. Mm-hmm. But about 60,000 people die from palliative sedation. And we do not know. There's no checks and balances. In all those cases of physician-assisted dying, we know exactly it was the will of the patient. There was an independent physician. The independent physician came twice, asked the patient if the patient was dement or if the patient was not sure. There was no qualifying. So we know that in the cases of physician-assisted dying, it's the will of the patient and only the will of the patient. I am not sure if that is the case when there's palliative sedation. I know cases where the family is complaining, the whole heritage is going aside because we're paying 3,000 euro a month to have all these nurses and all this care. And then all of a sudden someone dies. I don't know.
Yes, good
Whose
question.
will is that? So I think that in all the countries where there is legislation, it's the will of the patient. And one of the beautiful illustrations of my experience is Oregon. In Oregon, mind you, if a doctor says you're going to die within 6 months, you can get the means to kill yourself. And they're hardly ever used.
They hardly ever used?
Yeah, because the people have the means. And then, next week is my wife's holiday, birthday. So no, this week is not the right moment. Oh, I would like to see my grandchild pass his exam. Oh, so I'll postpone it. And then they postpone it, but they know that if they really suffer unbearably, they can do something about it. So I think that in many cases now, physician-assisted dying, but especially palliative sedation, is used too easily. And one of the beautiful illustrations of those 660 cases where only 14 qualified is that really taking your patient's demands seriously and not saying, oh, it's just suicidal ideations. No, but really taking the time to address an existential discussion with your patient, I think is really very important.
Thank you so much underlying this, but I would like now include Jan also to the discussion. Jan, there is a question from Igor.
Yes.
I think you have seen it. He writes, often mental health practitioners are faced with questions about whether patients can plan a pregnancy. We usually accept the risks of the impact of pregnancy on the risk of mental deterioration and the ability to carry the pregnancy to them safely for the mothers and child. Do you know of procedures, methodologies to better assess the risk of mental deterioration in people with severe mental disorders in pregnancy that can be used to make recommendations in response to patient requires? It's a little bit long, but I think you got it.
Yes. So it's a really interesting question, partly because of the way it's framed. Now, the bit at the end suggests this is patient-led, and there's no problem with that. I'm aware of articles that highlight that for bipolar affective disorder, the biggest risk is from the unplanned pregnancy, and making changes to medication before a pregnancy is attempted, making sure their nutrition is optimal, folate and B12 are taken care of, any other medical problems, monitoring can lead to a safe pregnancy. But the beginning of the question makes me very uneasy. It may not have been your intention, Igor, but it makes me ask, why are we setting a different threshold for people with A condition than from people with condition B? We're supposed to be combating stigma. All conditions are supposed to be equal. And I would ask you, are most pregnancies planned in the socio-demographic group you're looking at? Because if they're not planned, why are we asking different questions for this group? And you can see, I'm going to avoid the wish to take us back to something I said earlier, that this is about reproductive rights and reproductive education. And I'm going to fly the flag for the Netherlands, and Rutger Jan can pat himself on the back, because the Netherlands has the lowest rate in the world of combined teenage pregnancies and terminations, because they begin their sex education before children are 12. If you teach properly, if you give knowledge, people can make responsible decisions.
This is a very important topic, because in many countries, education in sexuality is not only stigmatized, it's forbidden. So
and it has become more and more complex. I was in Valencia this summer, and there was a great exhibition about LGBTQIA plus representations in art, and it was fantastic. Now, what I would suggest taking another look at this, in that this isn't about can people plan? It's about, do they have decision-making abilities? Now, the UK has something called the Capacity Act, in which there is a framework to determine if people can make decisions. And if they have that ability, you have to accept the decision they make. Why is that different for people with a mental disorder? Now, there are good reasons why we make it different when they don't have decision-making capabilities. But if they do, they've just got to understand it doesn't have to be a decision full of wisdom. We will all know plenty of stories of people where you and I would say, that's too young to get pregnant. You've changed the trajectory of your life.
I would like to add another question
yes.
regarding your topic, Jan. A question from a colleague from Republic of Moldova, Romania. How does the timing of pregnancy termination from conception to birth influence changes in the ethical approach? You mentioned it in your talk.
Back to front. It's about the legislation of your country. You may make a decision based upon when the notochord can perceive pain. You may make a decision based upon the viability of life. You may take the view that the social issues are much more important than the individual moral issues, and it's about the family. Now, it is not for me as an outsider to tell any country what is right. It's for you as a community to decide what is best for your community. And once that's in legislation, those are the rules. Now, Rutger Jan has highlighted the heart-rending actions that have to be undertaken when the rules aren't quite right. And there will be, no matter how perfect the system, always terrible decisions, because these aren't easy, and there's often not a right or wrong approach. But I'm going to paraphrase Doctor Who. Always be kind, never be cruel. And as Rutger Jan said, all we can do is walk with people when there is no other choice.
Yeah, absolutely. And you know, when it comes to abortion, I don't know what your experience is, Jan, but I've had many, many patients, women in their 30s, in their 40s, that had remorse or that had second thoughts about abortions. And sometimes I think we think much too lightly about an abortion. You know, even when the social circumstances are there, I think they need a lot of aftercare. You know, it's not a light decision. And when you have decided for good reasons and you really have thought, this is the best decision I can take, I think it's so important that we provide aftercare to not say, okay, well, the abortion is done, over to the order of the day, there's no mourning, you haven't lost anything. No, it has a huge impact. And I think it's tremendously underestimated how difficult it is to mourn properly about an abortion. Because, you know, it's theoretical, 12 weeks, 18 weeks, 20 weeks, you know, there's been life in your womb. And for good reasons, you have decided to terminate, but you have to cope with it.
Yes, I would like to add one question, because I see that the time is really running. This is a question to you, Rutger. Do cultural factors have impact on the acceptance of euthanasia by different communities or cultures? This is a question from Simavi Bahi from Turkey.
Yes, I think they have a profound effect. You know, when you look in the Netherlands, there are religious groups from Catholics and from Orthodox Protestants that don't even want to engage into this discussion because somehow they say suffering is something imposed by God, and if God thinks you have to agonize for 3 weeks, then there's no person that can contradict that. And I think that the same in the Académie de Médecine, there was a big book about the Jewish approach to medicine, and there was a big chapter that I was reading about physician-assisted dying. And then there were all kinds of considerations, both from the compassion side as from the more strong side, for this is something you have to bear, and this is part of what you need to suffer as a person to qualify for a better life afterwards. So I think these religious and cultural factors play a huge role. And they also play a huge role in how important it is that someone may decide for him or herself.
Last question to Jan, forensic psychiatry, maybe a short answer.
Sure.
How to forget that a patient is a criminal?
Okay.
Is a question from Emma Gruber from Denmark.
Yes. It's an excellent question. I would say you must never forget that they're a criminal. You've also got to remember criminals are human beings. They're just as deserving of care as the rest of us. You may need to bear in mind whether they're a serial liar, whether there's a risk of aggression or violence from them, but they still deserve treatment of their cancer, of their depression, their anger issues, whatever happened to them in their early life. They're entitled to treatment just the way anybody else is, but never forget that they're inside for a reason. Now, Meryam, you mentioned earlier, do you mind if Rutger Jan and I give a quick plug for the EPA?
Yes, please.
Well, just to add to what you were saying, in the medical oath, we don't make any discrimination for patients.
Yes.
You know, and one of the really very core issues in medicine is the safety of the patient. So we treat terrorists, we treat criminals, yes, we treat murderers, we treat people that have completely different political ideas as ours. That's part of our ethics.
Yes.
And in that sense, of course, you can never forget that someone is a criminal, but if he's broken his leg, you can't say, well, because you're a criminal, we're going to leave you with a broken leg.
Thank you very much. This was very important to be underlined, because our job is to do our job in a neutral position, and we should not punish our patients or something like that. No. We have, as mentioned before, the ethical principles of respect for the autonomy, beneficial, not